Okay, start. Okay, good morning, students. Good morning, all of you. You see, this boy is suffering with fever. 2 days back, he attended a birthday party of his friend. They served ice cream, chocolates, cool drinks, cool cake, whatnot, everything. Then he developed a fever. Next, you see here, this is also suffering with fever with the chills. He also attended, he went to beach to enjoy. In the beach, he took ice cream. And he also took some other food outside. Then he developed fever with the chills. What is the cause? You see, this is the Valdeir's ring. Valdeir's ring, an interrupted circle of protective lymphoid tissue at the upper ends of the respiratory and alimentary tracts. That is at the entry point of the respiratory and alimentary tracts. There is a ring-shaped arrangement of lymphoid tissue. Ring-shaped arrangement of lymphoid tissue. This is interrupted. You see, it is not a continuous ring. There is an interruption. That is why it is called interrupted circle. And here, this consists, there are different groups of lymphoid tissue. That is, see, this is the pharyngeal tonsil. This is also called adenoids. That is in the upper part. And tubal tonsil, that is in the upper side. That is in the 2 o'clock position. This pharyngeal tonsil, that is in the 12 o'clock position. And this is a 2 o'clock position. That is another tonsil. That is called tubal tonsil. That is surrounding the opening of the, it is auditory tube, or it is also called Eustachian tube. It connects the middle ear with the nasopharynx. Middle ear with the nasopharynx, and that is called tubal tonsil. Again, another one. This is the 4 o'clock position. This is our today's topic. That is a palatine tonsil on either side of the oropharynx. Next, at the 6 o'clock position, there is another tonsil on the dorsum of the tongue. That is called lingual tonsil. Lingual tonsil. These are all the lymphoid aggregations. They are encircling the entry point of the respiratory system and the GIT system. That is a entry of point around the oropharynx. That is called and nasopharynx. Around the oropharynx and nasopharynx. And this is called Valdeir's ring. This is very, very important short answer. Next, you see, this is the arrangement of the Valdeir's ring. You see, these are all the components of the Valdeir's ring. And here, these lymphatics are lymph from this lymph glands. It drains into different groups of lymph nodes in the cervical region. The cervical region. That is, if you see here, this is the retropharyngeal group of lymph nodes, and this is the jugulodigastric nodes. This is the jugular chain, and this is the submandibular group of lymph nodes, and this is the submental group of lymph nodes. From all these lymphoid structures, lymph drains into different lymph nodes. Okay, this is the Valdeir's ring. Next, today's topic, that is palatine tonsil. Palatine tonsil. Why it is called palatine? It is related with the palate, especially soft palate. That is why it is called palatine tonsil. You see, lingual tonsil, that is related to the posterior end of the tongue. That is why it is called lingual tonsil. Another one is the tubal tonsil. That is the, you see, this is the tubal tonsil. It is related with the opening of the Eustachian tube into the nasopharynx. That is why it is called tubal tonsil. And here, this is the pharyngeal tonsil. Nasopharyngeal or pharyngeal tonsil. This is the on the roof of the pharynx. That is why these are all the names given. Next, we see what it is. The palatine tonsil. First, you see what it is, where it is, what are the relations, with the surrounding structures and who gives stability to the palatine tonsil. Because it is a small structure, there must be some stabilizing factors, otherwise it may move. And who feeds? The feeding, that means what are the blood vessels, especially arteries, which are supplying to the palatine tonsil, and where it drains. And from this palatine tonsil, there is a drainage, that is a venous drainage, lymphatic drainage, and where it drains, and who stimulates, that is what is the nerve supply to the palatine tonsil, and who gave birth, from which structure it develops, and again, we supposed to know about the palatine tonsil. This is also very important. That means what is the applied anatomy? As a medical people, why you supposed to know about the palatine tonsil? These are all the things we are going to discuss in the today class. Next, what is palatine tonsil? First, you see what is palatine tonsil. First, you remember this is very important clinically, because this is the most commonly affected structure, especially in the children. That is, especially before puberty or in the before adolescence age. That is the school-going children. This is most common structure gets infected, because in those people the lymphatic, that is the defensive mechanism, that is immunity is not fully developed. They are exposing to different infecting agents, and it leads to the development of innate immunity, that is herd immunity. Because of this reason, whenever you go to there is a change in the environment. Suppose if you go from Vizag to some other area, Guntur, or if you go to the Vijayawada, or go to Nellore, or if you go to the Bangalore, there are chances for getting the infections, because you are not accustomed to that particular environment. The pathogens, that is microorganisms which are present in that area, they are new to your body. That is why your body reaction to that structures that leads to the infection, and you may get fever. And by the time period, over a period of 3 months or 6 months, you are accustomed to that particular environment, then your body develops resistance to all the pathogens or microorganisms which are present in that area. That is why this palatine tonsil, this is the most commonly infected structure, because it is the entry point. What is the job of the palatine tonsil? It acts like a sentry or a security guard. It acts like a sentry or security guard. It scans, it protects from our body the descending part of the GIT and descending part of the respiratory tract. It protects by nullifying the infecting agents. That is the most important function. Because of this reason, the palatine tonsil is located in the oropharynx. It is an almond-shaped mass of lymphoid tissue situated bilaterally in lateral wall of the oropharynx. That is in the lateral wall of the oropharynx. What is the shape of the palatine tonsil? It is an almond shape. Normally, it is almond shape, but because of enlargement of the palatine tonsil due to infections in different individuals, there may be variation. But normally, the palatine tonsil shape is almond shape. What is the location? It is situated on the lateral wall of the oropharynx. They are derived from lateral groups of Walde's ring of lymphoid tissue. Just now we had seen that is the lateral group, comes under the lateral group of the Walde's ring, and it encircles the commencement of the digestive and respiratory tubes. Because these two tubes are two systems, they are exposing to the external environment. External environment. We are taking air and we are getting food from the outside. That because of this reason, there are more chances for the infection or infecting agents may come in contact with these two systems. That is why at the entry point, suppose if you go to the CMR shopping mall, what they do? First, you can enter into the that is a compound of the mall. But if you want to enter into the main mall, you must be checked. Just like that, in our body also, there is a protective mechanisms and the checking points that is in the form of palatine tonsil. First, you see situation. What is the exact location of the palatine tonsil? That is very important. It lodges in a triangular tonsillar fossa sinus. Triangular tonsillar sinus. triangular tonsillar sinus, that is the exact location of the palatine tonsil. And what are the relations of the, what are the structures which are taking part in the formation of the triangular tonsillar sinus? That is important. If you see in front, there is a palatoglossal arch, and within that arch there is a muscle that is nothing but the same name, that is palatoglossal muscle, palatoglossus muscle. And behind that there is another muscle, another arch, that is a palatopharyngeal arch and muscle. And next is the apex of soft palate. The apex is directed above, that means the soft palate, and base it is formed by the dorsal part of the posterior 1/3 of the tongue. Posterior 1/3 of the tongue. You can see here, this is the palatoglossal arch, and this is the palatopharyngeal arch, and this is the apex of the triangular tonsillar fossa, and this is the base of the triangular tonsillar fossa. Here you can see clearly, this is the palatoglossal arch, and this is the palatopharyngeal arch, and this is the apex, and this is the base. The base is formed by posterior 1/3 of the dorsal surface of the tongue. The apex is directed towards the soft palate, and anteriorly it is by the palatoglossal arch. Along with this, within this behind or below this mucous membrane, or deep to this mucous membrane, there is a muscle, that is the palatoglossus muscle, and here behind it is formed by palatopharyngeal arch, and within this also there is another muscle, that is a palatopharyngeus muscle. Okay, these are all the boundaries. Next, the lateral wall, it is also called, we call it as a tonsillar bed. The lateral wall is also called tonsillar bed. That is the pharyngobasilar fascia, palatopharyngeus muscle, superior constrictor muscle, styloglossus muscle, and the glossopharyngeal nerves. These are all the structures which are related with the tonsillar bed, especially the pharyngobasilar fascia, palatopharyngeus muscle, superior constrictor muscle, styloglossus, and glossopharyngeal nerve. Apart from this, there are some other structures. They are also in the lateral to these structures, but basically these structures, they are forming the lateral wall, that is in the form of tonsillar bed, just like our stomach bed already we discussed. Okay, that is the, these are all the location, that is the location of the or situation of the tonsil, and these are the boundaries. They are bounding the, they are the boundaries for the tonsillar sinus. Next, coming to the size. The size of the palatine tonsil, it is not clearly constant, because in children the tonsil is enlarged, in adults it is diminished. Frequently the tonsils are infected, hence the exact size cannot be ascertained. Because suppose if you see in the children's, because they are more prone for the infections, because that is the immunity system is not properly developed, fully developed in the children. That is why they are more prone for the infections. And at the same time, they don't know what to take, what not to take. That is, what are the substances which cause infections, how to prevent, all these things they may not know. Because of this reason, there are more chances for the children to get tonsillitis. And in adults, already there is a dysfunction over, because by the age of the adult sense, we are all exposing to the different infecting agents or microorganisms of that particular or environment. Because of this reason, the tonsils are not actively participating in the disinfecting the agents, because already our body developed immunity to the particular infecting agents. That is why in adults it is diminished in size. Exactly the exact size of the tonsil, it is not certain, because it depends upon the infection. Suppose if it gets infected, it gets enlarged. If there is no infection, it may be small. Because of this reason, there is no exact size of the tonsil. And next, what it contains. What are the parts of the tonsil? There is first, you see, tonsil is having two surfaces, that is medial and lateral, two borders, anterior and posterior, and two ends, that is upper end, lower end. Two surfaces, medial and lateral, two borders, that is anterior border, posterior border, two ends, that is upper end, lower end. These are all the parts of the tonsil. You can see here, this is the palatine tonsil. Here, this is the upper end, and this is the lower end. You see, this is the upper end or apex. It is coming in contact with the soft palate, and here, this is the lower end. It is connected with the dorsal 1/3 of the or posterior 1/3 of the tongue. Okay, and here, this is the medial border. This one is the medial border, and this is the medial surface. This is the lateral surface. On both anterior to this anterior surface and posterior the posterior surface. Okay, these are all the different parts of the tongue, the palatine tonsil. Next, coming to the what is the specialty of the medial surface? We see in detail about the each surface and borders and ends, all these things. First, you take about the medial surface. It is free, bulges into the oropharynx, and is lined by non-keratinized stratified squamous epithelium. That is nothing but the mucosa of the oral cavity. It also lines the palatine tonsil. That is non-keratinized stratified squamous epithelium. That is the lining epithelium of the palatine tonsil. That is, it lines the medial surface. It lines the medial surface of the palatine tonsil. It is bulges into the oropharynx. Bulges into the oropharynx. That is already you know the pharynx. It is divided into three parts. That is the nasopharynx, upper one, middle one is the oropharynx, and below one is the laryngopharynx. Here the oropharynx, it is a site for the palatine tonsil. Here it is bulged into the oropharynx. The medial surface, it is lined by stratified squamous epithelium, non-keratinized. Non-keratinized. That is the epithelium. Next, the amount of bulging of the medial surface is not a true index of the size of the gland because it is buried in the tonsillar fossa and it may extend towards the lateral surface. Because of this reason, this is not the true index. The medial surface presents the following features. We see what are the special features which are present in the medial surface. We see. First, you see tonsillar pits. Tonsillar pits. These are small openings, about 12 to 15 in number. Each pit leads into mucous tubule known as tonsillar crypt. Tonsillar pits, tonsillar crypts. Tonsillar the pit continues as into the substance of the gland as a tonsillar crypt, which is surrounded by numerous lymphatic follicles. Numerous lymphatic follicles. That is the tonsillar pits and tonsillar crypt. You see here, this is the medial surface of the gland, and these are all the openings of the tonsillar crypts. That is in the form of tonsillar pits. These are nothing but the tonsillar pits. What you are seeing, these are all the tonsillar pits. Next, intratonsillar cleft. This is a special structure that is present only in the 40% of the subject. It is a deep semilunar fissure affecting the upper part of the tonsil, especially the upper part of the tonsil is like this. The upper part of the tonsil, there is a deep fissure, a semilunar fissure that is called tonsillar cleft, and it is present about 40% of the subjects. The cleft is a remnant of the pharyngeal pouch, especially the second pharyngeal pouch. It is because the tonsil, it develops from the endoderm of the second pharyngeal pouch. I think already class over. Okay, you know very well. Next, you see here, this is the, if you take the section of the tonsil, you can see this is nothing but the opening of the tonsillar crypt. That is nothing but the tonsillar pit. This is the site for the tonsillar pit, and this tonsillar pit, it continues as the tonsillar crypt. Here also, see, this is the tonsillar pit. It continues down as the tonsillar crypt, and all these crypts, they are surrounded by lymphatic nodules. Lymphatic nodules. This, what is the most important function of the palatine tonsil? To nullify or to phagocytose the infecting agents. Because of this reason, here through the tonsillar pit, the infecting agents comes in contact. They enter into the tonsillar pits, and they in here they're coming in contact with the that is lymphatic nodules. They try to nullify these infecting agents. That is the importance of the palatine tonsil. And tonsillar cleft, you see here, This is the tonsillar cleft. This is the semilunar fissure in the upper part of the medial surface of the palatine tonsil. Upper part of the medial surface of the palatine tonsil. There is a semilunar fissure that is called tonsillar cleft. It is the remnant of the second pharyngeal pouch. Second pharyngeal pouch. Next, coming to the another structure, that is there are two structures they may be present, that is especially the embryonic folds, that is plica triangularis. It is extended backwards as a triangular fold from the upper part of the palatoglossal arch. Palatoglossal arch. Palatoglossal arch, you know, that is the anterior arch of the that is the palatine fossa. Okay, from the palatoglossal arch, there is a one fold of mucous membrane that is nothing but the plica triangularis. It covers the upper pole of the medial surface of the palatine tonsil. After birth, it is usually replaced by lymphoid tissue. That is why it is called embryonic folds. And next is the plica semilunaris. That is also another fold. It arches backwards from the lower part of the palatoglossal arch and is replaced by lymphoid tissue after birth. These are the two things you must remember. That is embryonic folds. That is one is the plica triangularis and one next is the plica semilunaris. Okay, plica triangularis and plica semilunaris. Okay, this is the one fold. This is the plica triangularis. Actually, it is not properly named. Okay, this is the plica triangularis and this is the plica semilunaris. Okay, these are the two parts. Next, coming to the lateral surface or deep surface. The lateral surface or deep surface of the palatine tonsil, clinically, it is very, very important because this surface of the tonsil, it is coming in contact with the, or it is related with the most important structures which are supplying blood, which are draining the blood, and which are supplying, and most important blood vessels and muscles, all these structures, because the medial surface is open. It is bulged into the oropharynx. There is no specific relations, only features. But if you take the lateral surface of the palatine tonsil, this is it is accommodated in the tonsillar fossa or tonsillar sinus, and this tonsillar sinus, it is laterally it is related with many important structures. There are muscles, vessels, nerves, all these things. What are all these things? We see later. Okay, see now. Okay, it extends above and below and in front beyond limits of the tonsillar sinus. The tonsillar sinus, that is actually location of the tonsillar, that is tonsil. Surface is covered by fibrous capsule. First, there is a fibrous capsule which is attached below and above to the sides of the tongue. The relations of the lateral surface from within outwards. The relations of the lateral surface of the palatine tonsil from within outwards. We see one by one. Okay, that is the first. It is covered by laterally. First one is the laterally. It is covered by a capsule. Suppose if you take this is the capsule, and within this capsule, this is the palatine tonsil. First is the capsule, and outside this capsule, what are the relations of the lateral surface of the palatine tonsil? We see. First, you see this is the palatine tonsil. Okay, and here you see the green color one. There is nothing but the capsule. Capsule of the palatine tonsil, that is fibrous capsule. Fibrous capsule, and outside this fibrous capsule, there is a loose tissue. Loose tissue, and within the loose tissue, there is a paratonsillar. You see one by one. Loose areolar tissue contains paratonsillar veins. First one is the outside the capsule. The first structure is the loose areolar tissue. Within the loose areolar tissue, there are paratonsillar veins. These veins are very, very important clinically because if you want to go for tonsillectomy, if you want to remove the tonsils, you must protect these paratonsillar veins. Otherwise, if you cause damage, to the capsule of the palatine tonsil, and if you reach up to the paratonsillar veins, it leads to venous bleeding, and it may cause blood loss, excessive blood loss, or sometimes it may produce haziness of the field. In that condition, it is very difficult to identify the other structures, other important structures during surgery. That is why the paratonsillar veins are very, very important. But first, you have to restrict the your excision of the palatine tonsil without damaging the fibrous capsule. That is the best surgery. Okay. In some occasions, because of enormous enlargement, repeated infections of the palatine tonsil, and they may form at every time. If there is an infection, it produces a fibrous tissue, and this fibrous tissue may extend deep into the deeper structures, and it may attach to the there is underlying pharyngobasilar fascia and constrictor muscles, and it may reach up to the blood vessels and nerves. During this time, the surgeon must be very careful without damaging all these structures. He must perform the surgery. That is why the lateral wall of this palatine tonsil, it is clinically, surgically, it is very, very important. That is, first is the loose areolar tissue containing the paratonsillar veins. Next is the pharyngobasilar fascia. Pharyngobasilar fascia, next layer. And next is the superior constrictor muscle of the pharynx. And outside this buccopharyngeal fascia containing pharyngeal plexus of nerves and blood vessels. And arteries, that is especially the facial artery, ascending pharyngeal artery, and internal carotid artery. These are also having relation with the lateral wall of this palatine tonsil. You see here, this is the loose capsule. Outside the capsule, this is the loose areolar tissue, and this is the paratonsillar veins, venous plexus. Then this is the fascia, that is the pharyngobasilar fascia, and outside this is the middle constrictor or superior constrictor and some part of the middle constrictor, and this is the superior constrictor of the pharynx. And next is this is the buccopharyngeal fascia, and outside this is the styloglossus muscle, and this is the facial artery, okay, and glossopharyngeal nerve. These are all the structures that are having relation with the lateral wall of the palatine tonsil. In normal conditions, they may not be damaged, but in suppose if you go for the tonsillectomy in adults who received repeated attacks of tonsillitis, that is inflammation of the tonsil, that is a chronic tonsillitis. Because of this chronicity, there is at every time of infection, there is a chances for the formation of fibrous tissue. This fibrous tissue may extend deep, and it may adhere to the underlying deep structures. During tonsillectomy, it may cause damage to the paratonsillar veins. It may cause damage to these fascias and muscles, and finally, it may cause damage to the arteries, and sometimes it may cause damage to the glossopharyngeal nerve. Okay. Because of this reason, the lateral wall of the palatine tonsil, that is very, very important. And what are the structures forming the tonsillar bed is also important. Next, coming to the anterior border. Anterior, already you discussed about the medial surface, lateral surface. Next, coming to the anterior border. Anterior border, already you have seen, that is formed by the palatoglossal arch. Within this palatoglossal arch, there is a muscle, that is the palatoglossus muscle. And posterior boundary or posterior border, it is formed by palatopharyngeal arch, and it contains the palatopharyngeus muscle. And upper end encroaches the soft palate. Upper end encroaches the soft palate. It goes up. Already you have seen, that is, it goes into the upper palate, soft palate. You see, this is the here it goes into the soft palate, and next is the lower end. It is a continuous with the lingual tonsil and is connected to the side of the tongue by a band of fibrous tissue known as the suspensory ligament of the tonsil. This is one of the structure which keeps the tonsil in its position, or it maintains the tonsil position. That is the suspensory ligament of the tonsil. That is nothing but a band of tissue, connective tissue. It is connected to the side of the posterior 1/3 of the tongue. Side of the posterior 1/3 of the tongue. That is the suspensory ligament of the tonsil. Here you see, this is the exact position of the tonsil. This is the palatopharyngeal arch. This is the palatoglossal arch. This is the soft palate. This is the upper end. This is the lower end. And what you are seeing, this is the medial surface. Medial surface. These are all the tonsillar pits. Tonsillar pits. This is the apex. This is the base. Base, it is coming in contact with the posterior 1/3 of the tongue, and apex, it is coming in relation with the soft palate. And this is the It's okay. This is the palatoglossal arch. This is the palatopharyngeal arch, and this is the anterior border. This is the posterior border. Okay. These are all the structures related with the palatine tonsil. Next, factors which factors they are keeping the palatine tonsil in position. This is also very important. Factors keeping the tonsil in position. First one is the suspensory ligament of this tonsil. Just now we had seen it is connected to the posterior one of the side of the tongue, and attachments of the palatoglossus and the palatopharyngeus muscles to the fibrous capsule of the tonsil. The palatoglossus and palatopharyngeus muscles, these two muscles, they are connected with the fibrous capsule of the palatine tonsil. They are also keeping the tonsil in position, and the perivascular stalks, which keeps the tonsil in position. That is the surrounding blood vessels which are coming from the surrounding structures into the palatine tonsil. They are also helpful for the keeping the tonsil in its position. Okay, next, what is the structure of the palatine tonsil? This is also important. In brief, we discussed already. We discussed. We think we discussed in the the histology, but just a little bit we discuss here. It is a mass of lymphoid tissue and covered partially by the stratified squamous epithelium of the oropharynx. The tonsil consists of numerous lymphatic follicles which surround the tonsillar crypts. That is, if you take the section of the tonsil, these are all the things we can see. Each follicle presents a germinal center. That is, in the center, there is a germinal center and composed of lymphoblast. Because of this, because here you must remember one thing. If you see the lymphatic follicle, lymphatic follicle, within the lymphatic follicle, you see, this is the one lymphatic follicle, or if you take water, within the one lymphatic follicle, in the center it is less dense. There is a light colored, and the periphery it is dark colored. Why means in the center there are lymphoblasts. There is a immature lymphocytes, and because they are having more size, the size is big. Because of this reason, there are less number. What we are seeing, the dots, they are nothing but the nucleus of the lymphocyte. Okay, because the cell size is more, there are less number of cells. Because of this reason, less number of nuclei, and because of this, the periphery is dense and center is pale. Okay, dark and pale. Okay, because of this reason, these are the follicles, and that is the germinal center. That is the lymphoblast, and in periphery they form the lymphocytes, appear in the crypts, and are washed out into the salivary corpuscles. Here, as a salivary corpuscles. Here, the most important function of this crypts, that is a lymphatic follicle. Suppose this is the tonsillar crypt, and surrounding this tonsillar crypt there are lymphatic follicles. This is the tonsillar crypt. Okay, here this is the site for the antigen-antibody reaction. Antigen-antibody reaction, and here there's a infectious agents or noxious agents. They come in contact with this lymphocytes at this area. Because of this reason, all the tonsillar crypts, they are surrounded by lymphatic follicles. Lymphatic follicles. That is the reason why lymphatic follicles are surrounded by. Crypts are surrounded by lymphatic follicles. That is the reason. Next, coming to the arterial supply. That is what it feeds. It is receiving feeding from what are the blood vessels which are supplying to this palatine tonsil. That is anterior tonsillar artery, superior tonsillar artery, posterior tonsillar arteries, and inferior tonsillar arteries. That is the arteries which are supplying to the palatine tonsil. We are dividing the tonsillars into 4 groups. That is anterior, posterior, superior, inferior. Okay. Here, what are the tonsils, arteries which are coming from the above the tonsil? That is the dorsal lingual branches of the lingual artery. Dorsal lingual, that is the anterior branch. And next, posterior tonsillar arteries, that is from the ascending palatine branch of the facial artery and ascending pharyngeal artery. Okay, ascending, we see diagram, it is very clear. Here you see, this is the superior tonsillar artery. It is coming from the greater palatine artery. And here, this is the posterior tonsillar arteries. That is, one is the posterior tonsillar artery. First one is from the facial artery. That is the ascending palatine artery. And another is the posterior artery is also coming from the ascending pharyngeal artery. Ascending pharyngeal artery and ascending palatine branch of the facial artery. These two arteries, they are forming the posterior group of tonsils. Next, you see here, this is the anterior tonsillar artery. That is, both are coming from the lingual artery. And this is the inferior artery. It is the branch from the facial artery. It is a branch from the facial. The anterior tonsillar artery, it is from the dorsal lingual branches of the lingual artery, and posterior tonsillar artery from the ascending palatine branch of the facial artery, and ascending pharyngeal artery. Ascending palatine branch of the facial artery and ascending pharyngeal artery. These are all nothing but the branches from the carotid. External, this is the external carotid artery. You see, I saw it. Superior constrictor, that is a superior tonsillar. This is from the greater palatine artery. Greater palatine artery is coming from above. It is giving branch to the superior part of the palatine tonsil, and inferior palatine tonsil, that is the inferior part of the palatine tonsil, that is inferior tonsillar branches. That is, first one is from the facial artery. It is the principal artery. The inferior tonsillar artery, it is very, very important clinically because it reaches the antero-inferior part of the tonsil. It reaches the antero-inferior part of the tonsil, and it pierces the superior constrictor and fibrous capsule. Then it supplies to the gland. Here you see, these are all the arteries which are supplying to the palatine tonsil. This is the descending palatine artery. Okay, this is the superior tonsillar artery, and here this is the anterior tonsillar artery. It is coming from the dorsal lingual branches. This is the lingual artery. This is the dorsal lingual branch, and from here it is supplying to the anterior part of the palatine tonsil, and this is the posterior part of the palatine tonsil. Here you see, this is the internal carotid, this is the external carotid, and this is the lingual artery, and this is the facial artery. Okay, and this is the ascending pharyngeal artery. So the posterior part of the palatine tonsil, it is receiving blood supply from the facial artery, that is in the form of ascending palatine artery and ascending pharyngeal artery. These are the two arteries that are forming the posterior part, and inferiorly it is also receiving from the, that is the facial artery, that is the inferior tonsillar branch. These are all the branches. Out of these, that is the this one, that is this is the okay. The inferior tonsillar artery, it is very, very important because this is the principal artery of the tonsil. Here, these ligatures of these arteries, particularly inferior tonsillar artery, is an important step in the surgical removal of the tonsil. Suppose if you go for the tonsillectomy, you must be very careful with the what is the exact location of the blood vessels, which are especially the arteries which are coming and which are supplying to the palatine tonsil. Because if you want to remove the palatine tonsil, you must ligate, you must tie these blood vessels. Otherwise, it leads to bleeding, and it causes sometimes it may cause loss of the life also. That is, if you fail to arrest, because it is arterial blood, it comes like a fountain. That is why within a short period of time there is an enormous amount of blood loss, and it leads to shock. It is a hemorrhagic shock, and it leads to death of the patient also. That is why you must be very careful, especially the principal artery, that is the inferior tonsillar artery, that is a branch from the facial artery. It is very, very important during surgical removal of the tonsil, that is a tonsillectomy. Next, coming to the venous drainage. The veins drains into pharyngeal venous plexus via the paratonsillar vein. Here, the venous veins also very, very important. Already we had seen that is in the outside the capsule. That is a venous plexus, paratonsillar venous plexus. And here during tonsillectomy, this is the first thing coming in contact with the fibrous capsule. Just outside the fibrous capsule, this is the paratonsillar vein. Because of this reason, there are more chances for the damage to the paratonsillar vein during tonsillectomy. You must be very careful while doing tonsillectomy. Next, lymphatic drainage. The lymphatic drains into jugulo-digastric lymph nodes. Jugulo-digastric lymph nodes, and one lymph node situated below and behind the angle of the mandible is considered. That is at the meeting point of the common facial vein with the internal jugular vein. Common facial vein and internal jugular vein above, and below there is a posterior belly of the digastric muscle. Posterior belly of the digastric muscle. In this area, there is a small triangular area. Within that triangular area, there is a one lymph node, that is a principal lymph node, because whenever there is a enlargement of the tonsil, whenever there is an infection of the tonsil, that is a tonsillitis, this is the first lymph node enlarges. That is why it is called, there is a preliminarily enlarged in the infection of the tonsil. That is why it is called principal lymph node of the tonsil. Principal lymph node of the tonsil. Next, coming to the, here you see, this is the paratonsillar venous plexus. Here, this is the capsule. Just outside the capsule, this is a loose tissue, and within the loose tissue, this is the paratonsillar vein. This is the most common structure damaged during tonsillectomy, because if you once you damage the capsule, immediately beneath this or just lateral to this is the paratonsillar vein. That is why you must be very careful with the paratonsillar vein. Next, nerve supply. What it stimulates? That is the tonsil is supplied by glossopharyngeal nerve, greater and lesser palatine branches from the pterygopalatine ganglion. Pterygopalatine ganglion, from the pterygopalatine ganglion, that is the greater and lesser palatine branches, and glossopharyngeal nerve. These three nerves, they are supplying to the palatine branch. These nerves convey both general and special or taste sensation. General and special sensation. Sometimes a referred pain from the infected tonsil may extend into the middle ear, because both are supplied by the glossopharyngeal nerve. That is why if you see the children, especially children or maybe adults, if they develop tonsillitis, that is if there is an inflamed tonsil, there are more chances for the pain, referred pain in the middle. They also complain the pain in the middle ear, because these two structures, they are supplied by the glossopharyngeal nerve. Glossopharyngeal nerve, that is the ninth cranial nerve. It is the nerve up to the palatine tonsil. Next, from where it develops, who gives birth? That is, each tonsil is developed from the ventral part of the second pharyngeal pouch. Second pharyngeal pouch, that is especially the ventral part of the second pharyngeal pouch. From this area, the palatine tonsil develops. The endodermal cells proliferate outwards as solid buds. First, they proliferate, then which are subsequently canalized to form tonsillar pits and crypts. Okay, how the tonsillar pits and crypts are formed, you can get a clear idea. First, there is a endodermal cells that proliferate outwards. Then within this endodermal cells, there is a formation of canals-like structures that are nothing but the tonsillar crypts, and the entry point of this canals, that is nothing but the tonsillar pits. Next is how the lymphocytes develop. That is, the lymphocytes develop either in situ or within the tonsil, or they are also that is from the mesoderm, and they are all reached from the adjacent areas by the circulating blood and the lymph. The intratonsillar cleft is a remnant of second pharyngeal pouch. That is, the tonsillar cleft is nothing but the remnant of the second pharyngeal pouch. Next, coming to the another important point, applied anatomy. Applied anatomy of the palatine tonsil, it is very, very important, because this is the most commonly inflamed or infected structure, and it is especially in the children's. This is they are coming to the doctor with fever, chills, body pains, and inflamed throat pain, difficulty in swallowing. These are all the common symptoms. Because if you take some unwanted thing, food, that is, if you take cool things, some people may develop by taking the cool food or cool drinks or ice creams, and some people may develop by exposing to the AC or cool air. I suppose if you are during the summer, that is from the winter to summer, that transmission area, that is transmission time. During that time, you go for the ACs. That is the most common season for the infection of the tonsils. because of exposure to the cool air. And if you go outside, if you take some outside food, that is, and if you are not maintaining proper hygiene, personal hygiene, especially children's, they are fond of ice creams, cool drinks, and all these things. Because of this reason, there are more chances for the enlargement or development of the these tonsils. That is, the tonsils prevent infection. Basically, the tonsils prevent the infection to enter into the GIT or to enter into the respiratory tract. But sometimes, if the infecting agent is more powerful, the infection, the septic foci may develop within the tonsil itself. Suppose if you see in the gated community or in an institute, watchmen, they are the persons who are securing the institute. Suppose if the offenders, they are more dangerous, if they come with some advanced weapons, the security guard is unable to protect. In that occasion, he may die. Like that, our tonsils are also like a sentry or protective security guards. If the infecting agent is more stronger, the tonsil itself may get infected, and it may lead to the development as a septic focus. And from this tonsil, the infections may go into different parts of the body. And during that is the one point. Next, during tonsillectomy, the paratonsillar vein may be damaged, producing excessive venous hemorrhage. That is the another important point. That is during tonsillectomy. That is the removal of the inflammation of the tonsil is called tonsillitis, and removal of the tonsil is called tonsillectomy. That is better to avoid, better to postpone the tonsillectomy, because if you once you remove, there is no protection for the individual from outside these infecting or noxious agents. Better to postpone or better to avoid the tonsillectomy. Try to improve the individual resistance or immunity. That is just like now we are fighting against the COVID-19. There is no specific treatment. Only thing is to increase our personal resistance or immunity in the form of doing some yoga or exercise or taking nutritious diet and all these things. Some herbal products, Ayurveda, some other system, homeopathy, like that. If you take some other medicines, they try to improve your immune system. Whether you can prevent the repeated infections and frequent infections of the tonsillitis. You may postpone the tonsillitis that is up to the adolescence age. Because if you do early tonsillectomy, it is having its own complications. That is, the person is more prone for infections. There is no protective mechanism at the entry point of the noxious substances. That is why better to postpone. If you go for the tonsillectomy, you must be aware of the paratonsillar vein to prevent damage to the paratonsillar vein and produce venous hemorrhage. Next is sometimes patients complain of loss of taste sensation after tonsillectomy due to involvement of the glossopharyngeal nerve. Already you had seen the glossopharyngeal nerve. It is very closely related with the lateral wall of the palatine tonsil. This is the lateral wall of the palatine tonsil. This is the glossopharyngeal nerve. In some individuals, especially the complication rate of the tonsillectomy is 1 in 15,000 or 1 in 30,000. There is one death, but the death rate is very rare. But complications may develop, because suppose if you go for the tonsillectomy in adult people, adult age, in that occasion there is a chances for the formation of fibrous tissue. This fibrous tissue may adhere to the deeper structures, especially the structures which are forming the lateral wall of the palatine tonsil. They may adhere with this fibrous capsule of the palatine tonsil or the tonsil itself. There is a chances while removing the palatine tonsil, there is a chances for the damage to this nerve, especially the glossopharyngeal nerve. Here, this glossopharyngeal nerve is the nerve of the sensation, special sensation of the palatine tonsil and posterior one third of the tongue, especially the taste sensation. Because of this reason, if you cause damage to this glossopharyngeal nerve during tonsillectomy due to formation of adhesions. Adhesions means the fibrous tissue which is attached to the because of the repeated infections. Fibrous tissue is attached to the underlying structures. The adhesions may produce in the abdomen due to some abdominal surgeries. And like this, here also there is a chances for the formation of adhesions. They may cause damage to the this glossopharyngeal nerve, and it leads to the loss of sensation of the taste sensation of the posterior 1/3 of the tongue. Okay, these are the things. Next, development. Already had seen. You see, next here, this is the you see, these are all the different clinical conditions which are related with the palatine tonsil. First, you see, this is the acute tonsillitis. That is acute condition. Acute means that is less duration, less or initial type of tonsillitis infection. This is the picture you can see. This is the acute tonsillitis. These are the tonsils enlarged, and this is the uvula, and this is the palatoglossal arch. Posteriorly, there is a palatopharyngeal. This is the posterior wall of the pharynx. Okay, this is the picture of the acute tonsillitis. Acute tonsillitis, that is already mentioned. That is due to some bacterial infections, or sometimes the infection may be viral also. And this you see here. This is the chronic tonsillitis. Once there is acute phase is over, if you use to treat the patient, and the persons may continuously, there is some amount of enlargement of the tonsils. This is the chronic tonsillitis. Chronic tonsillitis. And again, you see, this is the peritonsillar abscess. Here, this is the peritonsillar abscess. What is abscess? Abscess is nothing but the localized collection of pus. Localized collection of pus. Because of the infection of the tonsil, the infection may spread around the tonsil, and it may produce a localized collection of pus. This is called abscess. If it is surrounding the tonsil, that is why it is called peritonsillar abscess. This is also another clinical condition related with the palatine tonsil. And next is the acute mononucleosis. This is also most dangerous clinical condition. It leads to may convert into carcinoma. May convert into carcinoma. That is a non-Hodgkin's, especially it's the most dangerous clinical condition. This is the acute mononucleosis. Next one is the strep throat. That is the streptococcal bacteria. It may cause infection of the throat. This is the appearance of the streptococcal infection to the throat. That is due to, it may also cause inflammation of the tonsils. That is called tonsillitis, streptococcal tonsillitis. And next is the tonsillolithiasis. Here the tonsillar pits and tonsillar clefts. Into the tonsillar clefts, there is a chances for the accumulation of this infecting agents and saliva and the degraded lymphocytes. All together, they form this stone. That is the tonsil stones. That is called tonsilloliths. Tonsilloliths. These are all the clinical conditions which are related with the palatine tonsil. Okay. They must, you see, in brief, within 2 minutes, we finish. Okay, first what it is, already you know. It is nothing but the lymphoid tissue in the lateral wall of the oropharynx. And there is a location is where it is. That is in between the palatoglossal and palatopharyngeal arches. And above the posterior 1/3 of the tongue. And what are the relations? That is, lateral relations are very, very important. That is a fibrous capsule of the tonsil. And next to outside this, there is the loose areolar tissue. Within the loose areolar tissue, there is a that is a paratonsillar plexus, and next outside this pharyngobasilar, and next to middle constrictor, buccopharyngeal fascia, and outside this styloglossus and the glossopharyngeal nerve, arteries, all these things are present. And stabilizing points, that is the ligament of the suspensory ligament of the tonsil, and that is anteriorly there is a palatoglossal, and posteriorly there is a palatopharyngeal arches. This stabilizes the gland. And feeding, that is anterior tonsillar arteries, posterior tonsillar arteries, superior tonsillar arteries, and inferior tonsillar arteries. And where it drains with the internal jugular vein. And nerve supply, that is from the glossopharyngeal nerve and greater lesser palatine nerves. And development, it is developed from the second pharyngeal pouch. And what are the complications? What are the clinical conditions which are why you supposed to know? That means if you want to become a surgeon, you must have an idea about the tonsil. What is the exact structure of the tonsil? What are the structures related with the tonsil? Especially the lateral wall of the tonsil is very, very important clinically for the tonsillectomy. And that is about the palatine tonsil. Thank you.